Welcome to, this is restarting the first of our series of our foundations webinars, which are basically geared towards going back to the foundations of digestive health, going back to the foundations of intestinal health and structure and function, going then into the structure and function of the microbiome, then looking at the gut organ axis, and then finally wrapping it all up with our interventions of what you can do with all this information. And so today is that first webinar of that 4-part series. So they do all build upon each other. But today we're really just going to be going through a review of intestinal structure and function, and then moving into going top to toe with our digestive health review of the digestive system. So this is, again, just a review of what we'll be doing. I will say that wherever you see a slide that has a star, this is a concept that is going to be expanded upon in later sessions. So you might want to just take note of that slide and save it for future webinars. All right, so today's goal, you may feel like you've gone back to your university or your college days of anatomy and physiology, depending on your profession, which may or may not bring back fond memories for some of you. Some of you, it might be a little traumatizing, but the goal is not to overwhelm. There will be a lot of information, but you will have the slides. So use these more as a reference tool. Just take in the information and try to pull some of that information that maybe you that are cobwebs, caught in the cobwebs in the back of your brain from years ago. Really, the goal for today is to look at that foundation, because if we understand the foundations, if we understand what's going on at that cellular level, then that is what then allows us to create the interventions and targeted interventions for our clients and for our patients. And sometimes I think we get lost in higher level knowledge, higher level understanding, and we forget some of these really core concepts that I'm hoping to go back over today with you. So that's what our goal is. So let's first start out with just reviewing some intestinal anatomy and physiology, going back to basics. So just again, as a review, the human body has several layers of organization. So we have all of our cells that then come together to make tissues, which then come together to create organs. And those organs come together to make an organ system. So like our digestive system is made up of liver, gallbladder, intestines, colon, small intestine, so on and so forth. So we have several organs, the salivary glands, that make up our digestive system. And these systems are what provide the cells with the materials that they need to actually function. So in the case of our digestive tract, we're assimilating nutrients that our bodies need in order to do all of its functions. We're eliminating waste so that that waste doesn't build up and continue to provide more toxic elements for us. Working to maintain temperature, pH, and other cellular processes. As we'll talk about, you have to have a proper pH for your enzymes to work in the gut. And if there's not a proper pH, then those enzymes aren't going to break down our food. And the digestive system in and of itself has 3 main functions, as I mentioned. So obviously the digestion of food, absorption of nutrients, and then elimination of solid waste. Those are the main reasons, but we will talk a lot about the immune system within the gut and some of that, some of those actions as well. Then we have the GI tract, which we'll go through as far as organs of the digestive system through the main ones, and then we'll talk about the accessory organs like the liver, gallbladder, and pancreas. But let's go back through what an epithelium is. So the epithelium is just a sheet of cells that covers a body surface or lines a body cavity. So we have our intestinal epithelium, we have the epithelium in our lungs that line the lungs, we have epithelium in our kidneys. So it's just this layer of cells that's essentially covering that cavity. And they form a boundary between environments. So obviously with as the intestines are concerned, with the epithelium, it's forming that boundary, but essentially between the inside world and the outside world. So as we consume food and we chew that food, we're also ingesting bacteria. We're bringing in various chemicals potentially. We have a microbiome that's already existing in our guts. And so we don't want all of what's coming in from the outside to just translocate through it into our system. That is part of what we'll talk about with leaky gut and that breakdown of that barrier. So it does form that barrier between environments, but it also serves to filter, absorb, helps with secretion, and also sensory reception. So there's a lot of functions that the cells of an epithelial layer will function as doing. And all epithelial layers are bound together by tight junctions, whether it's the intestine or the lungs or whatever. They're all bound by these tight junctions. And this is an important concept, especially when we talk about leaky gut, because as long as the contents are in the lumen, and the lumen is this innermost part here, you can see it's that central part of the tube where your bacteria and where all your food are going to be passing through. As long as they are in the lumen, they are still technically outside the body, because we have our mouth and we have the anus, two openings at both ends of the tube. And if it passes all the way through, then it's technically still outside the body. So when we have that breakdown, that's when we are allowing perhaps things that shouldn't be getting into circulation or shouldn't be getting into our bodies. If they are, then that could be triggering some issues. And then again, like I mentioned, the lumen has all the commensals and sometimes pathogens, depending on the situation. All right, so let's go through the small intestinal tract, looking at the various levels of the intestine. So there's 4 layers. We start out with the mucosa, which is where you have the epithelium. So that single cell layer that you're looking at here, those are your epithelial cells. And they participate in many different things. We'll break it down on the next few slides, but part of it is to secrete mucus. And the main functions are to really, of the mucosa, is really to just do a lot of that absorption and transport of nutrients, protecting the body from pathogens. We'll talk about the Peyer's patches, which if you look on the kind of the far left-hand side there, these are your major immune components of the small intestine. And so this is, we'll talk about that. Then you have the submucosa, which is just right underneath. And this is a more collagen-rich, whereas that mucosa is more mucousy. You have more of a collagen, more of an extracellular matrix that is going to join the mucosa to that muscular layer. And it's that muscle layer that then is responsible for movement. So we have peristalsis, which is the movement when we are eating and digesting and trying to propel those food particles and that food stuff through. And then we also have a motility complex called the migrating motor complex, which is working when we are not eating. It only works when we're in a fasted state. And this is really important for things like SIBO, because the MMC helps to sweep any residual food, any residual cellular debris or bacterial debris, helps to sweep that through down in a downward fashion, and it helps to kind of keep things nice and clean and clear and not allow that buildup. And it's this breakdown in the migrating motor complex in this muscular layer that then can lead to things like SIBO and bacterial overgrowth. And then we have the adventitia, which is a smooth muscle membrane that just basically is secreting some various fluids. Okay, so the epithelial cells, like as I mentioned, is this single cell layer. And as part of that layer, we have the enterocytes, which are your basically intestinal cells. And then there's various types of enterocytes. So we have Paneth cells, which are only in the small intestine, and they are going to be secreting various antimicrobial proteins. So as part of our natural machinery within our intestines, we have cells that are secreting antimicrobial proteins. So if we start to have a breakdown in these intestinal cells, it can compromise the ability of our own ability to create antimicrobial peptides. There are then goblet cells, which secrete mucus in the small intestine, and then we have neuroendocrine cells, which essentially are sort of our neurological brains of the small intestine, because they're activating nerve responses, they're initiating certain digestive actions, and they're kind of signaling and helping to detect harmful substances. So these are the cells within our epithelium. Now, there are other types of cells, kind of in 2 broad categories, with the exocrine cells, which are, again, in that mucosa. There's a few different types, and they're basically anything that are excreting certain substances. So it could be mucus, as in the goblet cells, could be enzymes. We know that there's the brush border enzymes within our small intestine, and we have a lot of enzymes that get secreted to help with digestion. Then we have endocrine cells, and endocrine cells are going to be our hormone secreting cells. So these would be secreting things like CCK or secretin, GLP-1, which is a hot topic now, And so these are all the hormonal components that kind of regulate digestion, appetite, satiety, and some of the other signals that then stimulate other organs to then act. So like in the case of CCK, which we'll talk about, helping with like gallbladder contraction and whatnot. And these secretions are regulated by the presence of chyme. And just as a reminder of what chyme is, it's just that partially undigested food. So it's that when we eat and it's getting all mixed up in the stomach and getting filled with various digestive juices, it's that chyme that then triggers some of these hormones to be released. All right, so these are some key differences. We'll talk a little bit more about this, but looking from the stomach all the way through in the colon, some key differences in the small intestine compared to the large intestine is that you'll see that there are these villi. So you have more of the fingerling projections in the small intestine, whereas you see more of the crypts, or less, kind of more of a muted, not really those fingerling projections in the colon. You also will see that in the small intestine, there are Peyer's patches. Those are the main immune components. They're very large sections in the small intestine that have a lot of immunological action, and we'll talk about why that would be a little bit later. And then there's the Panna cells, as I mentioned, which are helping to secrete those antimicrobial peptides. And then we have these microfolder M cells, which are part of the Peyer's patches, and they play a big role with communicating and interacting with secretory IgA and helping with preventing pathogens from wreaking havoc on our system. And then in the colon, you'll see that there's a much, much thicker mucus layer. We have an outer mucus layer as well as an inner mucus layer, whereas in the small intestine, we have just a kind of a thin mucus layer. And then in the colon, it's much, much, much thicker. And part of that is because we have a very large amount of colonic bacteria in our colon. So we need to have that mucus layer much more robust to kind of help as that buffer. And you've heard us at Microbiome Labs talk a lot about the mucus layer. And like as I mentioned, there's an inner and an outer. All right, so going into the colon now. So we've talked about the small intestine. We looked at a couple of differences in anatomy. So now let's look at the colon. And just as a review, again, that single layer of mucus, it's not attached to the epithelium. It might contain a few bacteria in the small intestine, whereas in the colon, you have that inner and outer layer. And the inner mucus layer is completely free from bacteria. So if you look over here, you'll see that there aren't any bacteria in this innermost part of the mucus layer. Whereas the outer mucus layer, it's a little bit more free flow, and it does contain some bacteria, not as much as what would be in the lumen, but there are still some bacteria that can be found in that outer layer. But the inner layer is completely, it's the only part in our body where we don't have any bacteria. Even things like urine and blood and the uterus and the vagina and all these areas that, the eyeballs, all these areas that we thought were once sterile that didn't have any bacteria, we now know that they actually do. And this, however, this one single layer does not. It's the only place that doesn't. And that's really important because it's also the place where we have the most bacteria in our colon. And it's important to understand this concept because if there's a breakdown in this mucus layer, that means that you have all the components of the lumen laying right on top of your epithelium. And this is when you can start to get that breakdown in communication. You can start to get, especially if you got dysbiosis or if you have any sort of pathogens that are, eroding that mucus layer, then you have a direct highway to the epithelium, and that is a direct highway into activating the immune system. So this mucus layer is really important in making sure that it's free from bacteria. So just as a summary slide for you that you can just kind of have as a takeaway over this section of the differences of the small intestine versus a large intestine. So small intestine, again, is more for nutrient digestion and absorption, and definitely a lot of immune system components there. It also has that thinner mucus layer, has some goblet cells, but not as many as what's in the colon. It also has more immune cells. It does secrete enzymes, and it has the villi and shallower crypts, whereas the large intestine is really mostly about absorbing water and electrolytes, having those bacteria, having that real thick layer, having a lot of goblet cells, which makes sense because goblet cells make mucus, and you have a whole lot more mucus in the colon, so you're going to have a whole lot more goblet cells. And there's no enzyme secretion in the colon, and there's no villi. All right, so let's talk about the immune system differences between the large and the small intestine and kind of break that down a bit, because again, we talk a lot about the immune system when we talk about gut health. So if you look at this chart here, you'll see that you have the different sections of the small intestine, the duodenum, jejunum, and ileum, followed then by the colon in sort of an anatomical sequence. And you'll see that villi length is greatest in the duodenum, and it just tapers down as you get to the colon. Again, just going back to how you get that lowering of the shallower crypts in the small intestine, you start to get more of a shrinkage of that villi length in the colon. And the goblet cells are increasing, et cetera, et cetera. So you can see the differences here in some of the immune components. And the reason for that is the colonic immune system is really focused on tolerating the large amount of commensals that are in our colon. We have to have an immune system that's really geared towards being able to select for and not completely freak out when we see all these bacteria that are there. So it's really geared more towards handling that massive number of bacteria. Whereas in the small intestine, the immune system is really geared more towards figuring out, okay, this thing that this person just ate, is that friend or is that foe? This thing that's coming in from the outside world that's maybe got, it's got proteins, it's potentially bringing in certain pathogens, maybe certain foods that, are not as healthy, or certain chemicals. And so it's trying to figure out, is this something that's safe, or is this something that we need to deal with and activate the immune response? So because that's where you're getting most of your absorption is in that small intestine. So it has to have a really discerning immune system to figure out if it's something it needs to absorb or if it's something it needs to activate and deal with. And so this is why you'll see that the secretory IgA is much higher in the small intestine. You have the T helper 17 cells, which as long as these are balanced, the T helper 17, they really help to protect against pathogens. The problem with T helper 17 cells is when there's imbalance or a lot of inflammation, which then it perpetuates things like autoimmunity and different immune dysregulation. But we do have a whole lot more of those in the small intestine. And then again, we have these antimicrobial peptide titers made by the Paneth cells in the small intestine, which is in much greater quantity in the small intestine versus the large intestine. So this is really geared towards distinguishing friend versus pathogen. And then we have the GALT. You've all probably heard about the GALT. And we've all talked about how, 80% of the immune system is actually in our intestines. And so this is the immune components of the intestines consist of about 4 different things. So you have the mesenteric lymph nodes. We'll talk about those in a minute. You have the GALT, which the GALT consists of Peyer's patches in the small intestine and these isolated lymphoid follicles, which are in the small intestine and the large intestine. So we have a couple of components that actually make up the GALT. We have the lamina propria, which is a part of the intestines. It's a kind of an area of the intestines. And then we have, of course, the epithelium, as we've talked about, which provides that barrier. So when we talk about just the immune system within the GI tract, it's not just the GALT, it's all of these things coming together to help with that immune regulation. So let's discuss Peyer's patches. These are immune cells in the lamina propria. So it's this kind of, we have the lumen, we have the epithelium. This is part of the mucosa, and the lamina propria is just kind of the section that's right underneath the intestinal epithelium. And it helps to these help to identify antigens and produce various antibodies. We do they increase in number. So we have a kind of our maximum amount of Peyer's patches between the ages of, 15 to 25, and then they actually start to decrease. So think about this, and if you are working with an aging population, or if you work with, people who are of advanced age, they do have immunological challenges sometimes. And this is why, our immune systems tend to kind of be more challenged as we age, is because we're decreasing these number of Peyer's patches in the small intestine, and that can affect our immunological regulation. And it does consist of various cells, B cells, T cells, mast cells, etc. So let's talk about the anatomy. Let's just break down the anatomy. So there's this very special section of the epithelium. So it's still part of this intestinal epithelium that we've been talking about this whole time, but there's a very special section that is right on top of wherever these Peyer's patches are. And it is where you have these M cells. So these M cells are these, specialized they're called microfold cells, and there are these pockets, and it's going to allow this direct interaction with the immune cells, and it also interacts with IgA, both the free and bound to antigens. So it's a way for your antibodies to figure out, oh, hey, here's something we need to bind to. And then it interacts with these M cells. And then it goes to in the subepithelial dome, where you have these antigen presenting dendritic cells. These cells are kind of sampling. So you have the binding of the immune, the IgA to whatever it is it needs to bind to. It comes in through this M cell. The dendritic cells are sampling to see, okay, what's going on here? What do we need to do with it? And then, it is able to go down and interact with the B cells in the immune system. So then that's part of the way of how the body is thinking, okay, do I need to deal with this, or is this something I can pass on and without any kind of problem? And so basically it's functioning as an immune surveillance system. So that's the function of these Peyer's patches. So you have that pathogen that meets an M cell. It's then presented to the dendritic cell. You then activate the lymphocytes, which then amplifies a response, which through these mesenteric lymph nodes, which I remember I mentioned that was one of the 4 components of our immune system. And the Peyer's patch being part of the GALT that I mentioned as part of that immunological action. And these B cells, they then differentiate into IgA secreting cells, which then gives you more of the IgA. IgA is kind of like your soldier marching around, looking and surveilling and seeing what it needs to attack in order to deal with whatever pathogen that's coming in. So essentially, what these Peyer's patches are doing is it's keeping the intestinal flora at an appropriate level, and it's helping to prevent any pathogens from wreaking havoc. So think about somebody who has SIBO, or think about somebody who has, celiac disease, or, some sort of, any kind of intestinal inflammation that's especially dealing or affecting the small intestine. They're probably going to have some immune system dysregulation and an inability to deal with these pathogens very efficiently, because when you have any of those inflammatory, or especially if you have something like SIBO, where you have this overgrowth of bacteria and you have a lot of this breakdown of the epithelial barrier, you could have disruption of the function of these Peyer's patches, which can then make people much more prone to various pathogens and immune system dysregulation and inflammation. So definitely be thinking about what's happening if somebody has a small intestinal inflammatory condition. What is it doing to that immune response? Then as we go down towards the lower part of the small intestine and into the large intestine, this is where there's a transition of the type of immune complexes from Peyer's patches to more of these isolated lymphoid follicles, which are a lot smaller. If we look at comparing the activity of a Peyer's patch, these isolated lymphoid follicles are much, much smaller, but they are throughout the lower part of the small intestine and then into the colon. So why is this all important? Why are we spending all this time on intestinal barrier function? Well, as we all know, intestinal barrier integrity is really important to keep us healthy, and it really depends on 2 things: tight junctions, an intact or an intact epithelial barrier, as well as an intact mucosal barrier. So you can see here in this picture, we're going to zoom out, this epithelium, zoom out the tight junctions, and look at these linkages here, because these tight junctions, as I mentioned, which are going to be connecting any epithelial barrier, are made up of various proteins. So you have your occludin and claudins, and you have your zonulin as well, that help to connect the cells, both intercellular and intracellularly. And then you have that mucosal barrier that consists of the mucus, the Paneth cells secreting their antimicrobial peptides, IgA, and then also it's that barrier. So it's helping to prevent anything from getting directly through this epithelium if there is compromise with tight junctions to the dendritic cells, which will then can activate that immune system. And so if you have this disruption of either the tight junctions and or the mucosal barrier, you will be having enhanced intestinal hyperpermeability, which is then going to allow these microbes to enter the body and trigger inflammation. So again, why is this important? Well, we know that there are environmental factors. So we have our westernized diet, we have all the emulsifiers, we have chemicals, we have endocrine disrupting chemicals, we have medications, we have all the things that can then lead to dysbiosis. And that dysbiosis is then going to contribute to impairing epithelial barrier function, especially if you have low short-chain fatty acid production, if you have an overgrowth of opportunistic or more pathogenic microbes. Which if we have that impairment of the epithelial barrier, we have more of that inflammatory response, and that's what can lead eventually to leaky gut syndrome, which we know leaky gut syndrome is really the root cause of many different conditions, inflammatory conditions. It underlies autoimmune issues, mood disorders, metabolic disorders. And so again, you'll be hearing a lot more about this in later webinars, but I wanted to kind of put it here and tie it into the function of what we've been talking about with some of the anatomy of the intestine. So let's just real briefly, we'll talk a bit about the gut-brain axis. I know this is something we've talked a lot about over the course of the last few months in other webinars, but I want to just revisit the vagus nerve. And again, you're going to get a lot more of this information later on down the road. But the gut-brain axis is this whole complex system that includes the vagus nerve. It includes the spinal cord, the brain, HPA axis, our gut microbiome, and our immune system that basically helps to sort of regulate this bidirectional communication between the gut and the brain. And our enteric nervous system has more nerves than in the spine, and it produces more than 30 neurotransmitters. So things like serotonin and GABA, acetylcholine, there are neurotransmitters that are made in the brain that are also made in the gut. And these hormones and these various peptides that the enteric nervous system create, some of them the neurotransmitters themselves not all of them can cross through the blood-brain barrier, but some of the various peptides and hormones and other byproducts can, and they then interact with the vagus nerve. And if we look at the communication direction, most of the communication signals between the gut and the brain via the vagus nerve are actually going from gut to brain. It's about 90% of those signals versus going from brain to gut, which is about 10% of those signals. And it is responsible for many different functions like respiratory rate, heart rate, digestion, that type of thing. So again, you're going to hear more about this in later conversations, but wanted to introduce it here. So let's take a pause and just kind of think about how some of this information might be used in your practice. Are you thinking about maybe some patients, or do some of these ideas, are they sparking some clues for you to maybe look for with some of your patients? But just think about how you might assimilate that into your clinical practice. We'll just take a breath, take a pause, and then we'll get into digestion. So this section, the second part of this webinar, is really just going through a review of the digestive process starting in the brain all the way down to the colon. Just because I think, again, to understand where the breakdown is, why somebody is experiencing symptoms, if you have a good understanding of the function of the digestive tract, it sometimes allows for it to be easier to identify where you need to do your interventions, what you need to target, as well as, leaning on whatever types of functional testing you might be doing. So let's start with the brain. So the brain, you have what's called the cephalic phase of digestion, which is that very first part before you've even eaten any food at all. And it's completely mediated by the vagus nerve. And so essentially what's happening is when you see, smell, if you're hungry, you think about food or the taste, start to, kind of at the very beginning stages of tasting food. What the vagus nerve does is it starts to activate the signals like acetylcholine and neurons in the stomach to start to secrete stomach acid. And the cephalic phase, again, before you've eaten anything, is about 20% of the gastric secretions associated with a meal, and it's about 30 to 50% of the total postprandial acid production. So there's quite a bit of stomach acid that starts to get released before you've even eaten anything. So think about, clients that are eating mindlessly, or maybe they're drinking their meal, so they're on the go all the time. So they're just grabbing a quick pre-made liquid meal, or they're just throwing a bunch of stuff in a smoothie, or maybe they're doing even like a pre-made smoothie, and they're not really taking the time to sit and prepare the meal. Not that you have to be cooking an extravagant meal at every sitting, but they're not heating something up maybe that could initiate that smell. If they're stressed at mealtime, do they have head injuries? Do they have maybe they're on a medication, or maybe they have something going on with them where they just have poor appetite and they just don't really have an interest in food, so that could affect the cephalic phase. There's certain things like nasal polyps or Parkinson's, smoking cigarettes, that will affect smell and taste, and so it's going to alter their brain signals about it's time for a meal, it's time to eat. Let's then talk about the mouth, going down to the mouth and the oral cavity. So chewing is super important. I know it's a very, very basic and fundamental, but I think we all could probably chew better. It takes about 30 to 40 times to break down food before swallowing. So make sure that your clients are actually chewing their food, because sometimes if they have undigested food particles in their stool, it's not because they need enzymes, it's because they just need to slow down and they just need to chew better. So that would be something to rule in or rule out. As well as other symptoms like bloating, gas, GERD, cramps, nausea. Again, not chewing enough, they could be, suffering from some of these symptoms. Now, if we think about the saliva is made up of several things. Definitely the mucus, obviously, to help with that moistening of the food. But then it has a few different enzymes. So it has amylase, which is going to break down starches. It has lingual lipase, which starts to help to break down fats. And then it has lysozyme, which will lyse the bacteria and start to prevent that overgrowth of any oral microbial population. So oral hygiene will be really important to explore with your patients. And it's not, some of you may already be doing it, some of you may not be, but it's a really important place to look and see, because again, the oral cavity is our second largest microbiome after our colon. And if we are not exercising proper oral hygiene, then we might be having some issues down the line in the GI tract, because we know that oral dysbiosis can definitely lead to gut dysbiosis and endotoxemia. And then these are some other things that any sort of dysbiosis in the oral cavity can lead to or has been linked with. So again, if you're looking at any sort of bioeffects testing, if that's what, the stool test that you're using, there are certain patterns that you can see on a stool test that might give you clues at an oral dysbiosis, or maybe something happening in the mouth that you would need to address. So things like having really high Prevotella, having really high proteobacteria, if they have really low stomach acid and you're getting a lot of these oral microbes translocating from the mouth to the GI tract, then that could also be a clue as far as their upper gut digestion. So just wanted to kind of mention that this is definitely something to consider. So what would you want to look for in a client's history? If they have TMJ, therefore issues with chewing, obviously any sort of dental issues, if they're on any sort of medication, or if they have any condition that would cause dry mouth, like lupus or Sjogren's, that's going to affect their saliva production and their ability to really chew, as well as being able to maintain an adequate oral microbial population. Bleeding gums, diabetes, and then again, are they chewing a lot? Are they the last to finish a meal? Those would all be things to ask about in your assessment. All right, so let's talk about the esophagus. So here the vagus nerve is again, that's going to essentially innervate the esophagus. And you have the lower esophageal sphincter, which is that sphincter, that bundle of smooth muscles at the bottom of the esophagus right before you get to the stomach. And if it gets too relaxed, that's when you get that reflux. And if it is too contracted, that's what will cause or can cause dysphagia. So these are the common triggers I think we're probably familiar with. So, first thing when you have someone who's dealing with a lot of reflux, definitely talking to them about these main triggers that are going to relax that lower esophageal sphincter even more. And then just some other signs of impaired relaxation, or if they're having more of the, kind of the contraction, then that would be things like, difficulty swallowing, chronic coughing, those kinds of things. So let's talk a little bit as we go from kind of this upper part down to now the meat and the potatoes of our digestive system, which is, the stomach, small intestine, and some of the ancillary organs. This is from the American College of Gastroenterology Clinical Guidelines. It is coming from their SIBO paper, but I think it's a good chart as a reminder of what we have built in to our digestive system that is essentially there to keep our microbes in check. So we have gastric acid, very acidic, that is there to kind of initially neutralize any bacteria that are coming in from, whether it's from the upper respiratory tract or something that we're consuming in our mouth. If it's getting to that stomach, it should be acidic enough to where it's neutralizing and killing most of what's coming through. We also have pancreatic enzymes that also have an antimicrobial aspect to them to neutralize bacteria. We have bile acids. Again, they're very acidic and they can denature certain bacterial membranes and affect them. We have a small bowel motility, so that migrating motor complex that I was mentioning, which helps as that cleansing mechanism, that sweeping mechanism in between our meals that allows us to pass through any sort of bacterial or digestive debris. We have our ileocecal valve, which is between the colon and the small intestine that prevents that backflow. And of course, our immune system, as we've talked about. So these are all the factors that we already have built into our own bodies that are there to keep microbes in check. So when you have someone who's dealing with any kind of dysbiosis, whether it be SIBO, LIBO, other, just general dysbiosis, look at these things. This is your list. These are the things that you'd want to address. And so we'll go through kind of each of these in the next few slides. So in the stomach, we have the epithelial lining, which is only mucus cells. Again, there's a lot of mucus in the stomach, which makes sense because it is very acidic, or it's supposed to be very acidic. And we then have these gastric pits, which is that entry to the gastric glands, which are secreting the gastric juice, or basically that HCl. And gastrin is the hormone that stimulates the secretion of that gastric juice. And within these gastric glands, so this is kind of a call out from this little image here, this gastric gland, we have the parietal cells, which are, again, making that stomach acid and also making intrinsic factor. And that's what's keeping the stomach pH between that 1.5 to 3.5. It's very acidic to be able to kill those bacteria and denature proteins. And then intrinsic factor is there to help with B12 absorption in the small intestine. You then have the chief cells, which are going to secrete pepsinogen, which is an inactive form of pepsin. So it secretes the inactive form, but then you have the stomach acid there that is then going to activate and convert to pepsin, which will then actually break down your protein. So this is why when we say, if we're looking at a stool test or if we're talking about low stomach acid, we're always thinking about the inability for that person to maybe properly digest their proteins because they're not activating their pepsinogen to pepsin to then be able to digest their food. And then the enteroendocrine cells, again, this is going to be secreting things like the gastrin, which is going to help to stimulate that gastric juice from the parietal cells. The gastric phase of digestion is about 3 to 4 hours, and it's activated from just food entering the stomach, but it can also be activated by things like caffeine. So this is why sometimes caffeine can cause people to feel not so great, or can make people feel kind of like they're having an acidic, like a reflux type. One, it also relaxes the lower esophageal sphincter, but it also activates gastrin, which is then going to activate the release of stomach acid. So you're going to have kind of a dual effect with caffeine. And then again, if you have a rising pH or if it's becoming more alkaline, then the parietal cells will then release more of that HCl to help with that digestion. So this is just a schematic on what's happening in the gastric phase of digestion, which comes after the cephalic phase, which is what starts out in the brain. So these are things to look at in a client's history for both low and higher stomach acid, or maybe potentials for ulcers or gastritis. I won't read through this because you can read, but definitely have this as a reference for you so that as you're going through your client and you're looking at what symptoms they're presenting with, these are some things you can go to see if it may be a stomach acid issue. Now, going into the small intestine, this is where most of your chemical digestion occurs. Again, we've talked a lot about the anatomy of the small intestine. We've talked about the function, why you have a higher immune load in the small intestine, because it is trying to figure out what it needs to digest and absorb. And so when you have that chyme that dumps out from the stomach and it goes into the duodenum, it then is going to release or stimulate the release of various juices from the pancreas and the gallbladder to then start that digestive process. And it can take about 5 hours for just one meal to be processed through that entire length of the small intestine. And it's going to coordinate with our ancillary organs. So in the duodenum, that's that first part of the small intestine. It's where you're getting, basically the duodenum has a more acidic pH than the lower parts of the small intestine because it's receiving all of those digestive juices. It's receiving bile, which is acidic. It's receiving the acidic chyme from the stomach. And when you have more of that acidic environment, it's going to lean more towards things like mineral absorption and some of these other things that might require a little bit more of a lower pH. The jejunum is the second part of that small intestine. Is where you're going to see things like B9 or folate absorption, and it'll continue that absorption of other minerals and carbohydrates. And then in the ileum, this is where you have that ileocecal valve that's separating the ileum from the colon. This is where you're getting a lot of the hormone signals to basically manage that valve. And it's where you're having some B12 and some bile salt absorption. So about 95% of your bile is actually reabsorbed in the ileum. So again, think about if somebody's missing any parts of their intestine, if they're missing their ileum, or if they've had, some jejunal resection, where are they then going to be challenged with some of their nutritional status in those areas? Now, the pancreas, again, has both endocrine and exocrine functions. We are very much familiar with glucagon and insulin, but most of the pancreas is actually exocrine in function. So about 80% is actually exocrine. And so there are these enzymes that function at a basic pH. So remember I was saying how when we talk about our digestive system maintaining proper pH, part of that is because the function of these various enzymes and hormones have to have a proper pH to do their job. So in the stomach, you have to have it real acidic to activate that pepsinogen to pepsin to break down proteins. You also have to have proper acidity in the stomach to then activate the release of bicarbonate, which helps to then neutralize the pH in the upper part of the duodenum. To start that neutralization process so that you start to get a little bit closer to neutral, 6 to 7 pH, so that then your enzymes in the small intestine can do their job and start and continue that process of protein, fat, and carbohydrate digestion. So when you have that food that's going from the stomach into the duodenum, that's when you get that CCK release. So that's going to signal along with secrete that or stimulate that pancreas to release bicarbonate to start to alkalize the pH. And CCK, again, it's going to release that stimulate release of bile, and then secretin is going to stimulate the release of bicarbonate from the pancreas. So you have both of those happening in the from the pancreas and then the small intestine. And the pancreas has 3 amylase, lipase, and then it has a few different protein digesting enzymes. So it's going to provide all the functions. So again, this is something when you think about fat digestion, I talk a lot about this with in various trainings, but when someone is suffering from fat digestion, you have to be thinking not only about bile, but also about pancreatic lipase, because it's the action of bile that emulsifies the fat, but then you have to have the lipase to then actually break that down and digest it. So it's a dual action for fat absorption. To be completely absorbed and digested is both bile and lipase. And so what to look for in a client's history, again, I won't read all of this to you, but you can see there are a few different things here that can definitely lean towards more of a pancreatic issue. Various things like diabetes, of course, which would put more pressure on the pancreas, low stomach acid, and a few medications. All right, so talk about the liver and the gallbladder. So the whole biliary system is a bunch of different ducts within the liver, the gallbladder, and the pancreas that then dump into the small intestine. And bile is made in the liver, but then what people don't always talk about is that it's then concentrated in the gallbladder. So if someone has their gallbladder removed, yes, it's true, they will still continue to make bile in the liver, but if they don't have a gallbladder, that bile can't be concentrated. And when I say concentrated, I mean that the bile that's in the gallbladder is much higher in bile salts, which helps with that fat emulsification, and it's much lower in water. So it has a very different composition in the gallbladder than it does in the liver. So just keep that in mind, that all bile is not created equal, and depending on where it is in the body at any particular time, it may have a different composition. But we know that bile is made of cholesterol is a big component. Most of our cholesterol that we excrete is actually through our bile, along with bilirubin, bile salts, and phospholipids. Bile does serve as a detoxification route for different toxins and hormones. It helps with emulsification of fat. It helps actually with regulating and maintaining IgA and helping to manage any sort of intestinal infections, and plays a role with our immune system. And it also helps to deliver vitamin D from the liver to the intestines, as well as other nutrients too. So it does play a bigger role than just fat emulsification. There are also signaling molecules. So bile acid receptors, which are sprinkled throughout our intestine and our body. When these bile acids bind to these receptors, they actually can regulate certain cardiometabolic action, so lipid and glucose and energy metabolism. So not only does bile act locally as a fat emulsification agent, but it also acts as a signaling molecule for other systems within the body. So when we eat fat, we get CCK released, liver, gallbladder release, bile, pancreatic enzymes, etc. So it's just kind of the function there. Now, a couple of pearls for you. So gallbladder emptying starts when the stomach begins to empty. So as the stomach's emptying, the gallbladder is starting to release its bile, and then it starts to refill when that gastric emptying is finished. So it's kind of this dual synergy that happens in terms of emptying and filling with the gallbladder and the stomach. The other thing is that the response of the gallbladder to CCK is calcium dependent. So what if you have somebody who's on a calcium channel blocker? For blood pressure, you might be decreasing that CCK response by about 80%. So you could have someone who's got a not as reactive gallbladder to these signals if they're taking certain medications. And then also too, if someone's overly stressed and they're in a chronic sympathetic state, the gallbladder is mediated by the vagal nerve. And so if someone's really stressed out and they're not in a parasympathetic or a rest and digest state, they won't be able to respond to that CCK as efficiently. And then these are some other signs of inadequate function that you can have as your reference. And so this is the summary table. We haven't talked about all of these, but I just put some of the main hormones, main digestive hormones, where they're produced, what stimulates them, and then what their action is. Again, this is more of a reference table for you as you're going through, just to kind of review some of the content that we've been discussing today. Now, in our large intestine, again, we've kind of talked about this. It's mostly there to help with absorbing water and electrolytes. It does, our microbiome actually makes some of the vitamins that we then absorb. We absorb about 20 to 50% of the vitamins that our bacteria make into our bodies. And by the time everything gets to the colon, about 90% is going to be absorbed. So it's really just about absorbing kind of that remaining water and then helping with that propulsion of those feces and that solid waste out into the rectum and then for elimination. And as I mentioned, vitamin K and B vitamins are produced by colonic bacteria, and we can absorb some of that. And there seems to be a little bit of regulation on, if our systemic levels are a little bit low, then our microbes will rise to the occasion, and it could help with closing some of that vitamin disparity. But so again, some of this you'll see on like a biometric stool test. And so that just tells you where the person is with their microbiome actually making the vitamins for them. It's not going to give you systemic levels, but it'll tell you what their microbiome is actually making. And that just gives you the different areas of the ascending, descending, and the sigmoid colon. The ileocecal valve, as I mentioned, this is just a picture of it. So it's going to be that little piece between the colon and the ileum, that lower part of the small intestine. You're going to hear a lot more about butyrate and short chain fatty acids in the next webinar when you start talking about more of the microbiome. But here's just a little bit about butyrate and the importance of it in terms of providing energy for the colonocytes, helping with promoting BDNF, One thing that I always recommend for people when you're doing your assessment is that you look at their transit time in your clients, because just because they're having a bowel movement every day doesn't mean that they are actually moving the entirety of their bowels every day. So one thing you can do is you can use sesame seeds, you can use corn, you can use beets, you can use anything that's going to change the composition, the color, or it's going to come out in the stool. And what you do is you have them time when they eat it. So let's say they eat some sesame, like a tablespoon of sesame seeds or half a cup of corn at lunch on a Saturday. You then want to see how quickly do they see it coming out in their stool. If it's coming out in less than 12 hours, then that means that their transit time is too fast and they're probably malabsorbing their nutrients. 12 to 24 hours is ideal. If it's sitting longer than 24 hours, and that means that you have more solid waste sitting in the colon. And I will tell you that I've done this with clients who are having bowel movements daily, completely normal looking bowel movements, but they eat something on a Saturday at lunchtime, and then they don't see it coming out in their stool until maybe early to midday on Monday. So we know that it's sitting in the stool or it's sitting in the colon for a much longer period of time. So it sometimes can be surprising to see exactly how long it takes for somebody to eliminate that food from their GI tract. And that would give a clue that maybe you need to support the transit time for those individuals. And then also too, this is where things like beta-glucuronidase can affect our hormonal, especially estrogen, detoxification and elimination. If we have imbalances in our estrobolome or imbalances with higher levels of beta-glucuronidase, which would be detected on a stool test, then someone might be recirculating their estrogen a lot more and could be contributing to potentially estrogen dominance. These are just some signs, again, for you as a reference of some factors that could lead to inadequate function and risk factors in a client's history. So essentially, in summary, we have a really complex intestinal and digestive anatomy that is really geared towards helping us communicating signals, ensuring that we have proper immune system, digestive and neurological function. And if we have any disruptions in that anatomy, it's going to affect the function. So this is where that functional nutrition, functional medicine comes into play, is understanding the anatomy and the function of our systems in the body and figuring out where there is a dysfunction happening. And so hopefully this will provide some clues and some little pearls for you. And over the next 3 webinars, you're going to continue to connect the dots between these foundational concepts, which the next one will be over the microbiome, which will further follow up on concepts that we've discussed in this webinar. So hopefully that was helpful. Please think about what was one new thing you learned or maybe relearned today. Really appreciate you all coming and listening, and hopefully we can have good discussion after the webinar. Thank you.